You're listening to Conferences Online Allergy Allied Health Series from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. Today is June 25, 2009. Our topic, Management of SubQ Immunoglobulin Therapy. Our presenter is Davie Floyd, National Field Sales Trainer from CSL Behring.
Well, this is Conferences Online Allergy Allied Health Edition, and today is June 25th. And we're joined by Davie Floyd, who is from Immunoglobulin, and he's going to show us how to use an infusion pump.
My name is Davie Floyd again from CSL Behring. A lot of people have not heard of us before, but we manufacture the one and only Immunoglobulin, which is allowed for subcutaneous use. We manufacture all our products out of human plasma, and this is one of the products.
Hi, this is Annette.
Hello, welcome.
Hello, thank you.
Hi, Annette.
Hi.
Why don't you introduce yourself? We just started.
Okay. My name is Annette Zampelli, and I'm one of the medical science liaisons of CSL Behring.
Great, welcome.
Annette, tell us a little bit about your background. Where are you from originally?
Outside of Harrisburg, Pennsylvania.
Okay.
And my background is that I, prior to joining CSL, I worked as a nurse practitioner in pediatric allergy and immunology. And I worked at Hershey for almost 16 years.
So you knew Diane Schuler?
Oh, yeah. She was actually the person that initially hired me into the allergy immunology practice.
Yeah, I know her well. So if you see her again, say hi.
I'll probably see her Friday.
Okay.
Annette actually lends us a little bit of additional expertise. She's actually a patient that's actually using Immunoglobulin as well. So some of the things that I'm going to discuss, unfortunately she's pregnant, so, well, it's not unfortunate.
I was going to say, did you say unfortunate?
Well, it depends, but it's probably fortunate.
But she's no longer flying around the country for us right now, but she's going to try to walk me through this while we do it on the phone. So, Annette, do you want me to take the point and go, or do you want to do it?
Yes. Go right ahead, and I'll just follow your lead.
Okay. So a couple of reasons why Immunoglobulin is different than IVIG. Is everybody familiar with IVIG? Okay, IVIG, the difference between IVIG and subcutaneous infusions is really unique. In the formulation, this is a 16% solution, goes into the subcutaneous tissue, where IV goes directly into the vein. But typically, when you give IVIG, you have a patient that's probably below the normal levels, and what you're doing is you're really bolusing, usually on a monthly basis, so it's either a 3 or 4 week basis, where you're bolusing a patient with a lot of proteins. So they're getting their entire dose. So what we're really doing is we're kind of overloading the system, so to speak, and then what we know is they chew through those proteins, or they use those proteins up throughout the course of a month, and some patients actually drop below their normal levels. So some of those patients who drop below those normal levels will experience what we call a wear-off effect, meaning that if you've dosed it once every 4 weeks, maybe on week 3, they start to feel, towards the end of that week, they start to get a little tired, a little bit more lethargic. So we call that a wear-off effect, where they drop below their ideal levels. With IVIG, some patients experience, when we bolus a whole month's supply into them, they'll experience what we call headaches, or they might have other complications. But it's pretty common with mimic cold symptoms like nausea, or they'll have a spike in temperature. Some patients may mimic what we call aseptic meningitis, where you'll see a patient maybe complain, maybe not at or during the infusion, but maybe about 8 hours after the infusion. They'll have a headache that'll come on for 2 or 3 days. So those are some of the side effects that you probably have seen in the past with IVIG. The difference between that and SubQ, since SubQ is released into the subcutaneous tissue, and it's released over a slower period of time, it fully gets absorbed, about 16 to 18 hours back into the bloodstream? So you get
Actually, it takes about 48 to 72 for maximum absorption to take place.
So there you go. So you can see it's probably not going to have a patient come into the hospital or go into an outpatient setting or in the home where they would actually tolerate a 48-hour infusion, where this actually gets inserted into the subcutaneous tissue and then it absorbs slower at a much slower rate. The result is that you get more of a steady serum rate. This is a weekly infusion as opposed to a monthly infusion. So weekly infusions mimic more of what a normal human being would actually have with their serum content. So that's one of the advantages of Immunoglobulin is protection. Really, what are we giving Immunoglobulin for? We're trying to build their immune system back up, so to prevent infections. But one of the things, this little brochure I kind of laid out, and I don't know if I left it. I apologize. Yeah, there you go. This particular chart on the inside just kind of shows the chart that I just showed. This was an overlay of a single patient, and this shows just the peaks and trough of IVIG. On the other side shows hemoglobin, where we actually got a 2-week study, and then you just kind of mimic that over for another 2-week study to demonstrate a full month supply. But one of the next pages, it kind of shows the systemic reactions or systemic adverse events that we have. And you can see from this chart that only 1.6% of all the infusions actually had a reaction that was similar to what you would see with the IV headaches. So that's pretty minimal. I had a physician tell me the other day that that was pretty much could be anecdotal even. You could wake up with a headache in the morning. So that's really dramatic when you look at the adverse profile of the two products side by side. So if you have patients who have reactions or have patients that actually have what we call a wear-off effect, hemoglobin is a great alternative for those particular patients. And then lastly, one of the things that we'll go into is poor venous access. That seems to be big. Most kids, most children's hospitals, usually venous access is probably the most difficult thing for children to get infusions. So IV starts sometimes are pretty complicated. Kids have to be stuck multiple times. So that's a huge advantage for your population with going to subcutaneous infusions. I'll pass around this tubing set here. It's probably just as good as any. This is a tubing set. Can we open this one up?
Yeah, you can, and there's needle links there too on that little thing you gave me.
This is a variety of different needle lengths. They come in different lengths and they come in different number of tubings. Some subcutaneous infusions involve sometimes multiple sites, and that's really based on the dosing amount. I'm guessing your average patient's probably going to be less than 40 grams.
Well, the patient themselves is heavier than that. The material given is yeah.
Well, typically, this is infused through a single syringe driver, and it goes through multiple sites, and it's inserted into the subcutaneous tissue. I've thrown this in my little suitcase enough times, so I've got it all tangled up here real quick. But what we use is a subcutaneous infusion method, and as I get this untangled here, let's get this here. Annette, I'm going to let you talk for a second.
Okay. The other thing you want to consider whenever you have patients that have had systemic issues with IVIG, when you do this subcutaneously, you're basically giving a quarter of the dosage once a week instead of the full dosage once a month. So the fact that you're giving a fraction of the dose and it's taking longer for absorption to take place, that is what really heads off these adverse effects that occur as a result of the high peak level. That is what you see whenever you're giving IVIG with the bolus. A lot of times patients, there's not a lot of things that can happen in our bodies that cause basically like a threefold change, and that's what's occurring whenever you have patients that have had issues with this kind of thing in the past, because you go from your low trough to receiving the IV bolus that gives you this super high peak that's usually 3 times higher than what their trough was, and then it gradually drops off over that 3 to 4 week period. That's what causes a lot of these adverse effects, and we recognize that there's really not that much of a need for the peak in the system, which is why it's so beneficial having the study or state that Vivaglobin provides subcutaneously. Another thing is there's a lot of patients that have other comorbid conditions such as kidney disease that causes them to lose protein in their kidneys, which protein is followed by immunoglobulin, or celiac disease, which is a GI disorder that you're probably well aware of that causes people to lose a lot of protein and immunoglobulin in their gut. There's other conditions as well that do the same thing. What they're basically losing when they receive the IVIG is they're losing that peak. And so most of those patients are never able to get to a therapeutic level to give them any kind of level of protection. So by switching them to subcutaneous, we see that since it's not going directly in their bloodstream, they're not losing that peak, and the immunoglobulin is actually able to get into their system and do a good job. I actually did have one of my adult patients at Hershey that had celiac disease, and we had her on a massive dose of IVIG and were never able to get her therapeutic. And her highest level was only 388. And that was on 60 grams of IVIG a month, and she was probably about 210 pounds, and so that's a pretty high dose for her. And by switching her to SubQ, we actually were able to lower her dose. Her level was completely therapeutic. Within 6 weeks, she had a level of, I think it was 547, and by 3 months she was up to 988. So, because don't forget, we're also not looking any longer at a trough level, we're looking at a steady state level. So you usually want that level to be somewhere between 800 and 1,000 or more. So that was extremely beneficial for her, and she felt better on that than she had in years on IVIG. So that's another thing to consider for your patients.
Don't you find that in general patients are able to get a lower dose with the SubQ than they do with the IV?
Exactly, and I believe that's because of the same thing. You know, you catabolize that peak so much more rapidly.
Right.
There's not a need for that, so your body excretes it for whatever reason. And so by being able to have them on subcutaneous, since you're not having that peak any longer, you usually are able to lower their dose, because we don't really recognize that people are rapid catabolizers of their IVIG when they're on IVIG, and we only recognize that once we switch them, and then we can get their dose at a lower dose. So yes, I have seen that on numerous occasions.
Okay.
All right, well, most of the audience here, are you infusion nurses? You've worked with us in the past, or you've seen this before? Are you going to be explaining it to other patients on how to do the self-dosing, or could you be doing it for them? Could be a variety of anything.
It could be. We could be doing some training in the clinic, possibly. It depends on where they're at in the community,
Okay.
what services are provided, home health to them.
Sounds like all of the above.
All of the above.
But so they need exposure, because the hospital is going to start implementing these pumps and having it available for when our patients are admitted, or if we do want to start a patient in the hospital. So the hospital is wanting training for all the nursing staff.
Okay.
Now, we do have an online training program that I'm going to be doing on July 9th. So if any of you would be interested in that, I'm sure David has some of those cards that the postcards that he can give you that would give you access to being able to call in, and it's a webcast program that will be occurring on that date.
And since this is being recorded, we'll be happy to put a link to that program on the website once the recording is posted.
Okay.
Well, we've got a number of training tools available to us. We actually, each one of the patients gets what we call a flip chart. And this particular flip chart is kind of like a step-by-step process. This is a leave-behind tool. It actually gets mailed to the patient's home as well when we actually get a prescription. So when your physician actually writes an order for Vivaglobin, they'll send out a welcoming kit, and that welcoming kit will actually have a response card. It'll give you a little bit of information about Vivaglobin. It'll have a DVD. It'll have a visual of actually a patient who does an infusion themselves in the home. And that's being updated right now as we speak, right?
Yeah.
I don't have any of those with me, but as soon as I get those, I'll get those down here so you have some samples. They get a patient brochure, just gives them a little bit more information today before I leave. I'll leave you additional patient brochures about how Vivaglobin is actually, just a small visualization, a little explanation. This is actually in Spanish, but we have it in English as well. I'll leave those for you. There's a little card in there that actually will be a little requirement for the patient to actually check a box. They can either get a backpack or they'll get a little bunny. So they get their choice of a little gift item, and in that little gift item, they actually have a little hot and cold pack. So there's a little round hot and cold pack in here as well that actually assists in some of the types of infusions. But typically there's also a therapy journal, and there's a little mini therapy journal in here for about 8 weeks. I'll pass this around. This is a therapy journal, and this you can actually record each infusions, and it actually has some information here that you can actually put down. After receiving my Vivaglobin, I felt, and it gives you some explanations. Talk to your doctor, but you can actually remove the vial labels and actually stick them directly onto the log itself. And so that could be something that, as a physician, if you wanted to monitor a patient, you can actually ask them to bring in their therapy journal and ask them to bring that in just to show you. You can flip through it to see if they've had any incidents. Sometimes when you ask a patient, if you haven't seen them for quite some time, how are you doing on this? Are you going to have any questions? Initially, they'll probably have some questions, but as they get into this process a little bit further, they may say, I don't remember. Let's go back, take a look. So this is what Vivaglobin looks like. Hey, thank you very much for sending me an empty vial. I appreciate it. This is
You're welcome.
A 20 ml vial of Vivaglobin. This particular product has been used, I think. So actually, Annette has actually used this. And so it gets packaged into a little box like this. So this is 20 mLs. Typical dose, let's use a patient 10 grams on a monthly basis.
Sure.
All right. So
Do the math. Make the math easy.
all right, let's make it really easy. Let's go to 40 because I got that memorized.
Do it.
All right. So if we have a 40-gram patient, what we're trying to do is convert grams into mLs, since this is packaged in mLs. So on the script, we're going to actually force the physician or pharmacist internally to identify, how do we equate that to mLs. It's a pretty easy calculation, but we take grams and divide it by 0.16, and we get in the total number of mLs. And we usually look at it, if you're given a dose for 4 weeks, we would divide that by 4. So we would have 40 grams would equate to about 62.5 mLs. Okay, so typically this is administered through a syringe driver. You can use a variety of different ones, but this one seems to be the simplest and easiest pump. I'm showing the Freedom 60 pump right now. You guys have actually acquired this pump for the hospital, so I think you've done a great service to your patients. It's so simple, it's hard to mess up. But it takes a 60 cc or 60 ml syringe. So this particular patient who is using 40 grams on a monthly basis would get 62 mLs on a weekly basis. Now, the pharmacy will round up and round down, approximately up and down with IVIG. So more than likely, they'll round it up to 63, but that would mean one syringe plus another syringe. And you'd either split it, or what you'll do is probably round down to 60 and see how they do and monitor that patient. So you try to make it easy as possible for everybody. Again, you can adjust your dosing up and down. But this particular syringe, you would actually draw up 3 of these vials. So 3 vials. This is then refrigerated, so you want to use it at room temperature. How long does it take for it to warm up, actually, for you?
I usually have it out for about an hour, and you want to make sure that you also take it out of the boxes, because the package insert is usually kind of helping to insulate the bottle. And so if you don't take it out, it'll take a little bit longer to warm up to room temperature. And that's also the best opportunity to look and make sure that the vial's not cracked and that there's no particulate matter floating around in it. There's nothing, the product doesn't appear cloudy or discolored in any way, and that the expiration date is appropriate and everything else.
So do a visual inspection of the vials to make sure that everything's intact. Sometimes, I haven't seen it, but in some cases it may get put into the refrigerator, and I think if you have a patient you're treating here, the hospital's going to do a good job of protecting the product, but if they go home, again, you want to communicate to the patients that, oh, by the way, you want to put it in the refrigerator, right there. You want to rotate your inventory. Typically, when they ship it from a pharmacy, a home infusion agency will actually ship it to them, eventually after doing additional training with them. But it may sit in the back of the refrigerator, so they want to make sure they rotate their stock and move it around a little bit. And everybody's refrigerators could be, when I was in college, I had one that froze in the corner, so they just want to make sure. We want to make sure we don't have any frozen plasma in there. So visual inspection of the vials. The other thing that's nice about that particular vial is it's got a little protection cap on it. You snap the caps off. You do your aseptic technique. We use a vented spike sometimes, or a needle. So you use a 1/2-inch needle. You can actually attach that to your syringe, so it's easy to just insert that into the top of your vial, and then you would draw up. Now, do you put air into your vial when you're using a needle?
When you use a needle, you have to, but when you use the vented adapter, you do not.
Okay. So in the environment at home, sometimes we use a vented transfer spike. In the hospital, you'll probably use just the needle vial, so you'll go ahead and insert. So if you've got 20 ml vial there, you'll probably insert, about 20 ml of air into that vial, and then you'll go back and draw it out.
Well, I suspect that our pharmacy will draw that up for us anyway, because they usually send them in a labeled syringe.
Perfect.
So I'm sure
you guys
that's
won't even need to do it.
Yeah.
And that's very possible in a hospital setting for that to happen, because that's the way it worked in our institution as well. So, and most times in those situations, they do have the vented adapters that they use under a hood system that's very a sterile hood system. So that's probably how they'll do that.
All right. So after you've drawn it up, you want to walk us through what you do next?
What I usually do, first of all, it's not uncommon to have a little bit of bubbles in the syringe because of the fact that the product itself is very viscous, and protein is prone to bubbling, especially if there's any increased velocity when you're pulling back on the syringe. So actually having a little bit of bubbles is not a bad thing when it comes to priming and tubing, because the tubing is microbore, so it's sometimes very difficult to visualize depending on how the lighting system is in your institution. So when you go to prime it, having a little bit of bubbles in the top of the syringe is helpful because it appears white when you're priming the tubing, so that you can kind of get a better visualization of where the air fluid line is. Now, Vivaglobin is much more viscous. We'll be using the Freedom 60 setup, and so the tubing piece that you have between the syringe and the actual needle set is what regulates the flow rate for that tubing. If you're doing pediatrics, you'll probably start out with a slower flow rate, and that flow rate calculator is something that you have to get from the Freedom 60 website, and it's not based on what you see with the label being, I'm not sure, Dave, if you have the old label that has mLs per hour, if you have the one that says F600 or however it's worded.
I've got mLs per hour.
Okay. That is not accurate in the sense that it doesn't actually flow at that rate, because keep in mind that Vivaglobin itself is much more viscous than the IV fluids that were used in determining those rates. And also that was going into a vessel, whereas we're going subcutaneously, so you have an increase in the tissue resistance pressure. So as a result of that, with the downstream pressure being so much greater, that flow rate's not accurate. So there's a calculator that can be obtained online. They did have some trouble with their server recently, but I do believe they've corrected that. That can get emailed to you or whoever's going to be determining what the flow rate's going to be to make sure that you have the appropriate tubing. And then based on that, that's how you determine what flow rate tubing you need to get for each individual patient. And when you go to prime it, because of the fact that it is more viscous and the flow rate tubing will slow it down a little bit, it's really hard to push. So I don't recommend trying to push it with your thumb and holding on to the flange of the syringe. What I do instead is I turn the syringe upside down on a flat surface and then just push the syringe down in a flat motion and prime it that way, and then you have better control over how the product's being released into the tubing and everything as well. And it's kind of hard to explain it over the phone, but David's seen me do this enough times that he can probably show you exactly what I mean.
Yes, I'm doing it as we speak. It's not too complicated. The one piece that she mentioned is this is the flow rate tubing set. They come in different lengths. So the slower the infusion is going to take place, the longer the tubing piece is going to be. The faster will be a shorter piece. So they do come in different lengths, and that's what the flow rate is. So this particular pump doesn't have a setting or a control to identify how fast. Typically, you'll start out kind of like IVIG, where you titrate up and then you go faster. Well, in this particular product, you use either a longer tubing, and then you go to a medium-sized tubing, then you go to a shorter tubing. So when the patients do get home, your typical infusion takes about how long?
Usually 45 minutes to an hour.
So if you visualize their monthly dose of IVIG takes 4 to 6 hours. Typically you would do it on a weekly basis, so you divide that by 4. So it's a good guesstimate to say you should be able to get this done in about an hour. And so patients see it like that. It just improves their quality of life a little bit, and there's issues. Some of your patients are going to be, this is going to be administered by mom if they're at home, or if they're here, so they're going to have a faster infusion time, so you may want to let them know up front.
Now, doesn't that probably vary by how many sites you use?
It doesn't vary by the number of sites, but it varies based on the patient's body weight, so the volume itself. So, yeah, for a 60 cc syringe, it'd take about, 45 minutes to an hour. If you go to more than that, it's going to equate that to longer. So I've got a patient who's like 90 kilograms. He's a big kid, and he actually does his over 2 infusions a week as opposed to 1 infusion at a time. And that would equate to like 8 sites. So to give you an idea, this particular product is 15 mLs per site, 20 mLs per hour. That's generally the way it's administered in our clinical studies. People fluctuate on that, but our particular, I got to speak to the clinical, 15 mLs per site. So that one patient who has 60 mLs, if he's getting the full 60 mLs, how many sites would we need?
4.
Okay, so that's how we determine how many sites. So we kind of work backwards. We look at the patient's body weight, what the dosing is going to be, and then we go, okay, if you got 60 mLs, you're going to need 4 sites at. If it's only 45 mLs, it's going to be a 3-site set. So in this case, I've got a 3-site set here. I don't have 60, but I'm not trying to confuse it.
And most of our kids are 2 to 3 sites, most of them.
2 to 3 sites.
Who determines the length of the tubing?
The length of the flow rate itself. The flow rate generally, how do you guys do it? You do it there in the physician's office when you write the script, right?
Well, it depends on, you don't necessarily determine the flow rate at that point. What you basically do is tell them how long you, as part of the prescription, how long you want the infusion to go in over. So, it would be like 60 mLs to be infused over 2 hours, or, however they choose to start out doing that. And then based on that information, the pharmacy would figure out what flow rate tubing would meet those needs.
So the pharmacy figures it out, and they send the tubing each time?
Yeah, and basically I wasn't figuring it out either. The pharmacy was doing it. But if I get complaints from patients or something saying it's taken me, 2 hours to do my infusion, then I'll find out exactly, can we up his flow rate tubing. And we have done that frequently, especially on our older teenage boys. They don't want to be done. They want to be done in an hour. And most of them can tolerate it, so we just change their flow rate tubing.
So you're just going to a shorter PP tube?
But can your doctors already do that?
Yeah, they do it. Our doctors, they're learning more, but, the pharmacists really help us in prescribing it. The little cheat sheets about how many sites and the flow rate calculator and stuff like that, those are really, our doctors don't memorize those, of course,
Very tough. The microbore tubing is going to have a certain number of resistance, even if you had a short tubing. You're opening up wide open. This only pushes at one speed, so the tubing itself controls it with that little tubing piece. But to be honest with you, most patients tolerate even the high speed, or the 1,200 mLs per hour that's listed on here. It equates to about 20 mLs per hour that actually push through with Vivaglobin.
And bear in mind that the flow rate of Vivaglobin itself is really only affecting the local site reactions. It has nothing to do with systemic reactions. So that's completely different than what people have been trained previously with IVIG, that the IVIG rate is dependent on how severe systemic reactions will be. This has nothing to do with that. The only thing that the flow rate for Vivaglobin is affected by is the severity of site reactions. So once patients have adjusted to doing subcutaneous infusions, that's how we can bump them up to a more rapid rate, because their skin stretches a little bit easier with each infusion.
Okay, so lesson 1, I'm demonstrating how I'm untangling my tubing again, okay. So lesson 1 is you leave your tubing taped up, right? You don't take the tape off?
Only after I'm done priming it.
Okay, so if we were priming, we would use this step. Let's just do that. It makes it a lot easier. So you basically, what you've done is you've taken your syringe, you've got a needle that's on the end of the syringe, you've drawn up, and hopefully, like you said, the pharmacy's already sent that up here this way and it's labeled with tubing. There's going to be, this will be capped off, right? You're then going to have a sterile environment. You're going to actually add the flow rate tubing if it's not already added to it. So this is one piece. You'll know if you don't have your flow rate tubing in, when you go to insert into the pump, and let's assume that you just attached directly to that tubing set, what will happen is when I turn this on, it'll push this plunger right on out. So you won't have anything. So this little has, it's got two purposes. There's a little round disc here that actually keeps it from being shoved out of the way. So we go to prime it. You could do a manual prime, or do you use the pump?
I do manual.
Okay, so she's using the manual. So she's actually connecting all the tubing sets together. And then what she does is she uses the surface of the countertop, pushes down, and forces that. Now she would want it, and you can see how easier, it's a lot easier to do it this way, without the tubing sets going all over the place. But she's got, in this case, it's a two-site set, so she's watching it coming down, and then she sees little bubbles. It's a little discolored. The plasma itself is a little like discolored tape, but it's really kind of tough to see sometimes because the tubing set's really good, unless you have, I've got over 40 eyesight, so it's killing me. But you get to about the point, if you look at these little tubing sets, there's a little metal needle. It extends down past it, so it's like an L-shaped. And there's a little piece of metal here. You'll actually then prime right down to it, towards that elbow.
I stop usually about an inch or so before that elbow.
So you're going to stop right about there. And the reason being,
the other thing I always do is I make sure that I flip the wings the opposite direction and put that W clamp back on in the opposite direction to kind of allow the plastic on those wings to lose their memory. And I do that because the wings themselves, that plastic, if you insert that needle directly into the skin and you're a little bit not quick enough to put the tegaderm dressing on, the wings want to close back up, kind of like a Venus flytrap. And what can potentially happen, especially when you're using a smaller needle length, is it can try to cause the needle to back out of the subcutaneous skin a little bit, causing either more of a site reaction or leakage at the site potentially. So by flipping the wings the opposite direction, it allows, even for the period of time that you're getting your supplies together and stuff like that, it allows the wings to lose their memory so that the wings lay flatter on the surface of the skin. And then I always do the dry prime method, which is what David was showing you, that you stop it about an inch or so before where that elbow is in the tubing so that you're inserting without having Vivaglobin on the tip of the needle, so you're not tracking that down through the intradermal layer, because it's the intradermal layer of your skin that is where the mast cells are at, and the mast cells are overstimulated and cause the release of histamine and make the site reactions worse. And so by not having the Vivaglobin track down through, you're less likely to see that kind of thing happen.
All right, I'm just going to connect this. This is a 2-site set, so I'm going to put 30 mLs into my syringe, so I kind of cheated a little bit. We're just going to then insert that after we've got it all primed. You go ahead and insert your needles at that point, or you go ahead and load your syringe into the driver?
Nope. I go ahead and insert the needles because you want to check for a blood return before you put the syringe in the pump. And then the other thing is, if somebody does forget to put their tubing piece on for the flow rate tubing, and they realize it at that point, they don't really have to worry about priming that piece because that piece is so short, and it's microbore also. It only takes about 0.1 of an ml to prime it. And keep in mind you're going subcutaneously, so if you have a little bit of air that goes subcutaneously, you're not going to harm anything at all.
All right, so this is I don't know if we pass around that little needle block, but the needle lengths come in different lengths. And do you have a rule of thumb on needle lengths, by the way?
Yeah. 4 and 6 is primarily for pediatric. 9 and 12 is for the adult population. There is a 14 that they also are making available now, but that's only available by Evans, which you can make sure that you have for your more obese patients. My kind of general rule is if you're over the age of 9, you should be on a 9 or a 12. And granted, that's kind of very generalized, but there's always exceptions to that. You'll see some children that are heavier that probably need a 9 that are under the age of 9, and you'll see some adolescents and adults that are smaller that may need a 6. But it's, for the majority of the time, that's a pretty standard rule that has worked for me in the past. And I had about 48 patients between my pediatric patients and adult patients that I transitioned to Vivaglobin before I left Hershey a year and a half ago.
All right, in this example, I've got a 2-site set. Your recommendation for needle insertion?
I usually prefer the abdomen because the abdomen is often the easiest access for people. You're going to see a more even distribution because, none of us are completely symmetric. So, we certainly have certain areas that will be better absorbing areas than others, but you want to also make sure that you can visualize the sites well. So abdomen is always a good place for that. That's more for the adult population. Pediatric, a lot of people tend to prefer the legs, or some parents even prefer using the upper butts and having the children lay on their tummies and watch a movie or something while they're doing their infusion. The most important thing is, finding out the comfort level of people as far as what works for them. But you definitely want to stay away from any major muscle area, 2 inches away from each needle insertion site, and 2 inches away from your belly button or any scar.
Good. So if you have an inch to pinch, like I do, that's probably the easiest way to insert the needle. You're pinching an inch. Some people will actually use, like in home, they'll actually use a cold, like a hot cold pack. They'll actually put that on and kind of like deaden or numb the skin a little bit. You use an example of some people in the home actually use pet rocks and put them in the freezer. So, or they can use tablespoons and use the concave side of the tablespoon. But then you go through your aseptic technique and you make sure you wipe that down, let the alcohol dry. Insert your needles at that point, tape them down, and then do you go ahead and do a pullback, right? Do a flash to see if you hit a vessel or anything.
We don't. you don't have to do it individually, one site at a time. You can just pull back generically hard on the syringe and look at all the sites and see, because that saves time, and if you pull back hard enough, you'll be able to see the bubbles move. And as long as you see the bubbles move backwards a little bit, if you were going to get a backflash, you would have. The one and only time that I ever did hit a vessel, I actually saw it before I even did my blood return, so because it came back immediately. So, I mean, chances of that happening are extremely slim, especially if you're pinching and poking.
Our patients use Elamax or Emlet cream, too, before their infusions.
Good.
Well, I try to avoid that just because it's extra preparation time. You have to have that on the skin for at least 30 to 60 minutes to be effective. And then sometimes if people do have site reaction, then you have to kind of troubleshoot. Is it the product? Is it a tape allergy, Tegaderm, adhesive tape issue, or the Elamax or Emla? And the thing that's nice with doing the freezer idea is it's only a matter of minutes. It only takes such a short time to hold something to the site to make it numb. And then the other thing is when your skin is cold, it tends to be more taut. So it's easier to pierce through the skin whenever it's cold than whenever it's at room temperature.
Okay, well, I'll let them know.
So there's a variety of different techniques you can hear. It's kind of like as you go. I know I've got other offices who use Emel cream quite a bit. They have a tendency to kind of bend that side a little bit too. They like that. Anyway, so we're going to load the syringe into the driver itself now. And this particular driver, there's only one way. I like to leave the numbers up on the top surface. Just makes it easier. You can tell how much you've infused and how much you haven't infused. But these wings lock into this particular pump one way or the other. So you're going to need a syringe that's like that. If I go to put it in here, I've got this pushed. This is actually moving the syringe driver forward. So what I need to do is back that out. To do that, all I do is turn the pump. At this point, you can even get your patient involved and they can turn it, hold on to this, turn the whole pump itself, or just wind it up. So it's like a wind-up toilet. Kids, I don't think have a problem with it. Usually, people our age who've seen other pumps probably go, wow, what is that? It's too simple. This is made out of material like a football helmet, so you can drop it on the ground. Although we don't want them to do that, we want to make sure it's going to take care of itself. But there's really not a whole lot that can go wrong with this. But insert the syringe itself. The flanges will go in just perfectly into that side. Then you make sure you have this little round disc on here, so that it'll pump back out if it won't. So you know you don't have your flow regulator tube on. But at this point, you've got it wound all the way back. You would turn it on. If this has got product in it, it's going to be quiet. But I don't have product in here, so I'm going to go ahead and clamp it off, and it's going to take a while to be quiet because it's going to push some air through. But this is your on switch, off switch, on switch, off switch. Wind it up. Really, that's about all you have. So you turn it on. As I do that, that drives this little black mechanism towards the syringe, pushes at. It's still pushing, but you can see how quiet it is. That's what the sound is when you have product in there. So if I fill this with water...
So it's on right now?
So it's on right now.
Oh.
Just the initial part till the syringe driver gets in place is noisy, and then once it hits the product,
So
it's
it puts
quiet.
a certain amount of pressure on it, and then the pressure regulator controls how fast it flows through.
So that's how it works. At that point, what do you do next, Annette?
Then you just let it go. And I check it intermittently because, again, since it doesn't make any noise, you can't really determine if it's actually running very well or not. And bear in mind that if you do meet a lot of tissue resistance, the pump will actually automatically slow itself down. As David said, I am pregnant. I have 5 weeks to go, and I still use my abdomen. My OB doctor requested that I continue to do that because of the fact that you get better distribution of product and absorption abdominally than anywhere else. As a result, though, it does take longer for me to get my infusion because of the fact that, things are stretched a little bit more. So I have more tissue resistance. So what used to take me about 45 minutes to do actually takes me close to an hour and a half now. And that's just obviously because of the fact there's more tissue resistance than what there used to be. So that's something to keep in mind, too, and that's something that, the Freedom 60 calculator cannot account for. And I'm already on the 1200 flow rate tubing, so there's not any faster flow rate tubing that I can use other than that. So that is something also to keep in mind. And that's actually a good thing because a lot of the other pumps that are out there don't slow down when they have tissue resistance, they just keep on plowing through. And that can cause more tissue trauma and irritation and more site reaction problems than what you will notice with the Freedom 60.
Now, this particular one has like a Tegaderm type of thing, a clear adhesive bandage. You make sure you put that in, you take that down, that kind of thing. You did your flash. At the complete of your infusion, do you go ahead and remove the needles themselves and throw away the entire piece into the sharps container?
Yes.
So at this point, you're done with your infusion. You're literally going to have to just kind of wind it back a little bit. You got to turn it off to get that thing to go. So there's the saw, and you wind it. It won't do anything. Turn it off. Then you wind it. That'll move that back enough where you can actually then, and if you wanted to have it ready for the next time around all the way, but you just pop it out, and you may have to just kind of go back a little bit and pull it out and remove. So at this point, you have everything in here. I've seen it where they've instructed patients to actually put this in, needles in, and they use the syringe and actually throw everything away in the sharps container and use this as a plunger to kind of push it down into the little sharps container. So that's the end of your infusion. At that point, you're going to document then again on your therapy journal to let them know, hey, where do they use, what sites they use, and go ahead and remove the labels themselves and stick them directly on there.
Now, when you insert the needle goes in perpendicular, not at a 45-degree angle like SubQ.
Correct.
Right.
Yep, this particular needle set goes in like a 90-degree angle, so it goes directly in. There is a soft set, there's an angled type set, there's different needle sets that are out there. For this administration, for this particular product, we have found this is probably the best 90-degree angle just because it doesn't get kinked. This product is pretty viscous, so it's pretty thick, so you actually don't have any issues with that with these types of needles. There's 3 or 4 different manufacturers that make them. It looks like the one that you brought in today is the one that we use most of the time, or you see most of the time in the home.
Does the product ever go out the needle and then backtrack along the needle track and come out the skin?
Only if you don't have the needles long enough, because that's one of the primary reasons that you get leakage at the site. Or if it's not in the entire way, like I said, if people don't, if those wings try to push off the skin and back the needle out a little bit, those are the 2 main situations that I've seen where you get leakage at the site. The only other reason that could potentially happen is if somebody's too active when they're doing their infusion, it can allow that hole to stretch just a little bit around the needle, and things go path of least resistance. We know that. So there's always the possibility if somebody's doing a lot of bending and stretching and things like that while they're doing an abdominal infusion, they may stretch that hole enough that it allows a little bit of backing up of the product. So, it's not that they can't do things, but you want to kind of try to discourage them from being too overly active. I usually choose that time to sit down in my recliner and watch TV for a little bit or watch a movie, and that's my downtime just because, I can do other things, but I prefer that, just to sit there for a little bit and let it go and make it less likely to see anything like that happen.
And the Freedom Pump actually comes with a little fanny pack, backpack thing, and the kids sometimes will walk around with them. I don't really encourage it, especially in the younger kids, because you don't want to dislodge a needle. But, they do have that option, and we did have one kid that was very active during his infusion.
So you don't put it in and then play touch football with it?
No.
No.
It's nice enough to, if you need to use the restroom, you can go use the restroom. If you need to go into the kitchen and get a drink or something like that, get up and move. But, one of the things that's nice about this product is it does improve the quality of life for people, gives you a little bit more freedom. But I think a lot of physicians that I see, since it takes about an hour, they'll ask their patients what their favorite TV show is. They'll say, what's your favorite TV show? And let's say the kid says, I like watching, I don't know, what's my kid watching right now? Nickelodeon on 8 o'clock or something. So he says, okay, well, guess what? We'll do the first visit here in the hospital. We'll demonstrate and show you. And then eventually, if they do it at home, they'll say, do it on a Thursday night during your show. So get your supplies out, get your drug out, put it out there at 7:30. If your show starts at 8 o'clock, you'll be all ready to go to start your infusion. Then they're more apt to actually sit still and watch the show. And at the completion of that show, they should be completed with their infusion. So that seems to have worked pretty well for most physicians and patients.
Dr. Portnoy actually has a family of 3 that are all doing this.
Oh, really?
And they
do it together?
They all do it together.
They have one show they all like? I can't find out.
They're doing different things, but they all three get infusions the same
So they
day.
have three
around that same time.
instead of sharing and doing.
Yeah.
Yeah, they have 3 different pumps.
We got 3 things coming off of that one tube. They could all just kind of have one thing on each kid or something.
There's a wide range of ages there.
I got a new patient referral the other day from a physician in Omaha, and this particular child is 8 years old. She's only 35 pounds. So she's going to be using a smaller needle, and it's just a single site as opposed to multiple sites. But, there are single site sets. So it goes from like 1 site set to 8 site sets. I mean, there's even a 12 site set, but typically most patients are somewhere between, 2 and about 5. You'll see when you get to 6, you're looking for places to put needles to keep them apart from each other. But it's a very easy therapy. It's a lot safer than what IVIG is in the past, and the concerns with that. We don't have a black box warning label or anything with that with regards, and I think it's about the metabolic absorption rate that you have. We talked about 48 hours as being an absorption rate to get fully into the bloodstream, so you get more of a gradual increase in the proteins, and then once it's there and you do it on a weekly basis, you're just repeating that and you're getting more of a normal serum content. So patients have they reported to you in the past that they feel better, or they...
Yeah, they like it. The only people that have had complaints, and we have had a few people go off, 2 of them actually, and they were teenage girls. They have body image issues, and I think just even the small amount of site redness or swelling, they really have problems with it. So those are the only 2 that have had issues. It was teenage girls.
Especially in the summertime. If you have teenage girls who want to wear bikinis and play out, but I have 2 of them right now. I've got a 14-year-old and a 15-year-old. One's got a torn ACL, so she's now upset she can't go outside with her scar tissue. What I'm going to show now is the site reaction. That's a good segue into this. Typically, we showed you the adverse event profile was very, very low with headaches and things like that, but a fairly common with IVIG. What's unique to this, if you've infused a patient with IVIG, you've probably done a very good job of educating those patients of what phlebitis is and what those signs start to look like. Redness, soreness, swelling, maybe elevated temperature at the site. Guess what? This mimics everything you just described, but it's more of an injection site reaction. And in our clinical trials, the majority of people who had the infusions reported at least 1 injection site reaction. So it's fairly common initially. What we're doing is, imagine we're putting fluid in between layers of skin. So when you do that, initially you're stretching or you're spreading those layers of skin out to create like a reservoir to hold that. So if you're doing 15 mLs per site, you're putting 15 mLs, approximately in that one particular location. So initially there is going to be some stretching that's going on, so there might be some irritability. We talked about maybe using temperature to get the needles in so they're less painful, but when that product is in there, sometimes you're stretching the skin where it's really taut, and in Annette's case where she's talking about where she's pregnant and doing it abdominally, she's got her skin is a lot tauter and it's actually going slower. She still has a reservoir, but a new patient, you might start to see this pump to slow down. This pump is going to be like a little train that goes over the hill. I think I can, just keeps on pushing. So we want to make sure our needles are in tight, that the fluid doesn't back up into the site, then we have the right needle length. Okay, that's really important, the needle length. And we have a deep enough needle to get into the SubQ tissue, not deep enough that goes into the muscle, but not too shallow. And I think initially we weren't concerned too much about the right needle, and it was getting into the, we were creating some problems where we started creating more and more injection site reactions. But it's minimized quite a bit over the last 6 months to a year or so. But I wanted to show you what those look like. This is a mild reaction, and then there's a moderate reaction. So we kind of pass that around. You guys had a chance to look at it. I wanted to make you familiar with it, and I want you to familiarize your patients with it just because they probably got trained on what phlebitis looked like, but to avoid phone calls back here into your clinic, but also to see what you're going to see. You'll probably see typically a mild reaction initially on most of these patients. If it goes to a moderate, then what's happening is probably there's something like, as you said, the needle itself is leaking, or you've moved around or something, or the needle's not long enough, or it just could be that the patient's flaring up in one of those locations just because it's a new therapy, that location.
Yeah, most of the time it's new therapy or the needle's not long enough in the cases that we've had. And it's easily corrected.
Usually pretty corrected.
Yeah.
In our PI, we used to recommend rotating sites. We followed the protocol for doing SubQ infusions for insulin injections, and they recommended rotating, so we rotated. I can't talk to it, but Annette can talk to it. Annette, what is your recommendation on injection sites?
Typically, I think it's actually better not to rotate sites because it allows the skin to get more used to in those specific areas to stretching a little bit more. And just as we've seen with people that have ports and things like that, you know, by inserting needles time and time again in the same general vicinity, you become desensitized, that, you know, you don't feel the discomfort or anything anymore of the poke. And you'll notice that if patients use the same general vicinity with their abdominal or wherever they choose to do their infusions, that will happen as well. And then you'll see less and less site reactions over time because of the fact that those areas of skin are more absorbing and more accepting of the Vivaglobin itself. Also, keep in mind that when you're doing an infusion, this is a hypertonic solution. It's a 16% solution, so what ends up at 15 mLs in this site until it's actually absorbed with the osmotic pressure and everything else that occurs to allow things to be absorbed across the membranes actually grows from 15 mLs to probably 20 to 25 mLs as the body excretes its own extracellular and intracellular fluid to dilute down the product and allow it to absorb properly across membranes. One of my pediatric patients had said to me one time, he's like, so when you do your infusions, how long does it take after you do your infusion to stop jiggling? And I'm like, what do you mean jiggling? And he said, well, every time he gets his infusion, he runs up and down the steps at home. After he gets his infusion, he notices that his, as I was saying, just keep in mind that it's not uncommon to have that jiggling effect initially after the infusion as the body allows release of its own extracellular and intracellular fluid to dilute the product. And it's not painful, but it just feels funny to people at first, and then it goes away in a matter of hours. But that's one of the things that, you know, it's hard to say if it's not necessarily a site reaction. It's part of the whole process, and that's actually a very normal thing. And that gets better with time, too.
Well, how do they get the product? Do they get it 1 month at a time, 3 months at a time?
In the home, they actually get it shipped to them once a month.
Once a month.
Once a month.
That actually depends on their home care pharmacy, because I get my product at a 3-month supply.
Okay.
Cool. All right. Well, I'd really like to thank you guys for demonstrating the pump and the Vivaglobin. It looks like a great product. We certainly use quite a bit of it, and we'll probably be using more of it. So thank you for such a great product.
Good. Thank you very much. Appreciate it.
If any of you guys have any further questions that you need to contact me, David can give you my contact information, and I'm happy to answer your questions by email, telephone, whatever. So
and we'll post
make sure you give them that information for me.
We'll post that on our website, and also the information about the web conference that you're going to be having, the webinar, whatever, so that other people can join you.
Good. I really appreciate that.
All right. So thank you.
Thank you.
Thank you.
Bye-bye.
Cough does come out. Typically
This has been an ACAAI production. To learn more about Conferences on Lyme Allergy or the American College of Allergy, Asthma, and Immunology, go to www.acaai.org. See you next time.